Good morning, everyone. Thank you, organizers and the chairpersons for giving me the opportunity and inviting me. So actually, I am the last minute replacement for the original speaker, Dr. Jyotirup Goswami, who was supposed to actually present both of these. So because of some last moment problems, he could not come. So I am presenting this entire presentation on his behalf. So I'll be presenting two articles, which are essentially for treatment of local recurrence for prostate cancer after initial definitive radiation. So one of them is SBRT and the other one is LDR brachytherapy. The first one is SBRT for re-radiation for locally recurrent prostate cancer after definitive radiation. I don't know why this font has changed. So the objective is to decide the treatment of locally recurrent prostate cancer after definitive radiation, which is a matter of debate. Treatment alternatives in this scenario are mostly salvage prostatectomy or palliative hormonal therapy or androgen deprivation therapy, which are mostly burdened by a significant risk of systemic and local toxicity. Stereotactic re-radiation is an emerging approach, potentially allowing a non-invasive local therapy having a chance of cure. However, data confirming efficacy and tolerability are currently needed to support this technique in current clinical practice. And this article describes the experience from a single center cohort reporting long-term clinical outcome and safety after cyberknife robotic SBRT. So Dr. Shambist might be very interested about this. So the data is of 57 patients consecutively treated from June 2012 to February 2021, which were collected and analyzed. All patients underwent previous definitive radiation for non-metastatic prostate cancer and were affected by biochemical relapse defined according to European Urological Association criteria. Macroscopic evidence of intraprostatic recurrence was detected in all patients through 18F choline PET CT scan and MRI. Patients with metastatic or regional nodal disease were excluded. Patients underwent cyberknife robotic re-SBRT, and the dose was 30 gray in 5 fractions every alternate day. During follow-up was assessed every 3 months. Was E version 4.03. After a median follow-up of 58.8 months, biochemical relapse were detected in 40 for a median biochemical relapse-free survival of 52.8 months. Metastasis occurred in 26% of patients with a median metastasis-free survival, which was not reached. 26% patients died for a median overall survival of 83.2 months, that's almost 7 years. At univariate analysis, PSA more than 2.5 nanogram per ml was significantly associated to worse biochemical recurrence-free survival and metastasis-free survival. Concurrent ADT was associated with worse metastasis-free survival. None of these factors persisted in an independent predictor of outcome at Cox multivariate analysis. Grade 1, grade 2, and grade 3 late GI toxicity were recorded in 3 patients, 2 patients, and 1 patient respectively, which we can say negligible. 11 and 8 patients developed grade 1 and grade 2 late GU toxicity, which is also very less. So to conclude, re-SB to be a safe and viable treatment option for recurrence after definitive radiation with 5-year median follow-up. However, prospective data are awaited to develop correct selection criteria and guide current clinical practice. The second article is on salvage low-dose brachytherapy for locally recurrent prostate cancer after therapy. Again, the objective is to clear, but local salvage treatments are gaining interest. Retrospective single institution analysis of clinical outcomes and treatment-related toxicity in patients in 125 LDR brachytherapy for locally recurrent prostate cancer after radiation was conducted. And this is again a single center study. Total 94 patients with an isolator were included, and they undergone treatment with LDR brachytherapy between 2006 to 2021. So over a period of almost 15 years. Median follow-up was 34 months, essentially less compared to the SBRT cohort. Initial radiation was external beam radiation in 73 patients, which is like 78% of the entire cohort, with a median dose of 76 gray, or iodine 125 brachytherapy in remaining patients with a prescribed dose of 145 gray. Median PSA at salvage brachytherapy was 3.75 nanogram per ml, which is more than the SBRT cohort. The median interval between first and salvage radiation was 9.4 years. Histological proof of local relapse was available for all patients other than one. The result says that salvage LDR brachytherapy was administered to either with the whole gland, which includes 70% of patients, where the dose was 120 gray, whole gland with a boost, which consists of 20% patients, where the whole gland received 90 gray and the boost dose was up to 145 gray to the MR-defined GTV. Partial volume like hemigland or ultrafocal, which was given to 9% of patients. And the dose was 120. So 32% of the patients also received androgen deprivation therapy. 4% of the patients were CRPC. So coming to the results, failure-free survival was 82% and 66% at 2 and 3 years respectively in the whole population. The only factors associated with failure-free survival on multivariate analysis were hormone sensitivity at relapse and EAU prognostic group. Late grade 3 urinary and rectal toxicities occurred in 12% and 1% of the patients respectively. No significant difference in toxicity or efficacy was observed between the 3 implant volume groups. So to conclude, the efficacy and toxicity results are consistent with available data and in particular with the LDR group of the Muster meta-analysis published in 2020. Salvage brachytherapy seems to be an effective and safe option for locally recurrent prostate cancer. A whole approach in this context could be interesting to reduce late severe toxicities, especially urinary, but data on large studies are lacking to establish its efficacy. So my take on this are patients who are having only focal recurrence or local recurrence within prostate after initial definitive radiation, irrespective of type, whether external radiation or brachytherapy, should be or can be considered for re-irradiation with proper technique like SBR or brachytherapy. And by this, we can avoid systemic toxicity for a long time. We are definitely not going to discuss about the financial toxicity associated with systemic treatment. Thank you so much.